Bismillahirrahmanirrahim. Assalamu alaikum dear students. Welcome to your channel The Anatomy Canvas. In today's embryology class of the GIT, we are going to discuss with the development of the midgut. So learning objective for the 2 days class are to describe development of midgut, discuss the physiological herniation, then the mesenteries of the intestinal loops and its clinical correlates. Midgut extends from the cranial to the caudal intestinal portal or anterior to the posterior intestinal portal, and it is in wide communication with the yolk sac. So this is the wider communication of the midgut with the yolk sac. The intraembryonic coelom is in wider communication with the extraembryonic coelom. Midgut forms the third and fourth part of the duodenum, jejunum, ileum, and 2/3 of the way along the transverse colon. Its development produces most of the small intestine and portion of the large intestine. So posterior to the midgut, there is the splanchnopleural layer of the coelomic cavity is present, which will form the dorsal mesentery of the midgut. While in anterior part, although the folding of the embryo has started, but it is not completed, and midgut is in wide communication with the yolk sac. So intraembryonic coelom is also connected to extra, and the coelom is in wide communication with the extraembryonic coelom. So at this stage 14, midgut has increased in length more than the axial length of the embryonic body, and with elongation of the dorsal mesentery, it then bulges ventrally deviating from the median plane. So what happens in 5th to 6th week, the size of the embryo is smaller as compared to the developing midgut and its intestinal loop, and this cavity becomes peritoneal cavity, then becomes smaller for all of the loops to lodge into the cavity. So the loop bulges out from the umbilical ring into the extraembryonic coelom. So midgut has a cranial and caudal loops. While it is forming, it has two loops. One is the cranial and other is the caudal loop, also called the proximal and the distal loop. So midgut loops rotates around axis of superior mesenteric artery. So you can say this is the superior mesenteric artery, and this superior mesenteric artery is the blood supply of the midgut, and it forms an axis around which the midgut rotates. So first rotation of the midgut takes place before the process of the physiological herniation, and this is about 90-degree counterclockwise, in such a way that the cranial limb comes to the right side and caudal limbs to the left side. So you can see this is the direction of the rotation, and after the rotation has taken place, the cranial limb is the proximal limb is present. This one is the proximal or cranial, which is present on right side, and this one is caudal or caudal limb or the distal limb, which is present on left side. So this is the way the forming the primary intestinal loops, and at this time it is nearly 6th week of the gestation that the physiological herniation through umbilical ring takes place, and it is because of the reason because first the liver has greatly increased in size, second mesonephros are developing over here, third the large intestinal loops occupy much greater space, and the abdominal cavity is too short to accommodate all of the intestinal loops, so they herniate through the umbilical ring into the extraembryonic coelom, which occurs at 6th week of the development. Again, please remember this is your MCQ as well. So midgut then extends into umbilical coelom, having already rotated through an angle of 90-degree anti-clock or counterclockwise, viewed from the ventral aspect. This relative position is approximately maintained so long as protrusion persists, during which time proximal limb, which forms small intestine, elongates greatly. So in this diagram you can see the proximal part is greatly elongated, and there is the folding, and because of this elongation and folding, the dorsal mesentery of small intestinal loop also adopts a pleated appearance as well. By the time the fetus has attained a length of the 40 millimeter, that is the 10th week of gestation, peritoneal cavity has enlarged and a relative size of liver and mesonephrosis much less. So at this time, the re-entry of the gut occurs rapidly and in a particular sequence during which it continues the process of rotation. There is a further rotation of 180 degree. So in other words, the intestinal loops rotate total 270 degree clockwise. First 90 degrees are before the herniation, and later on 180 degrees after the process of the retraction of the loops into the intestinal cavity. Also remember that the time when the loops are retracted and they re-enter into abdominal cavity, that is 10th week of gestation or 40 mm size of the fetus, is also your MCQ as well. So proximal limb returns first. This is again another point. You must remember that the proximal limb enters first, and the jejunum is the first part to enter, and it mainly lies on the left side, and the ileum mainly on the right side in the subhepatic abdominal cavity. So in this diagram you can see this is the area of the jejunum and this small intestinal loop forming ileum which are present in the right side, and there is also the pleated appearance of the mesentery, and mesentery finally acquiring its position. So as they re-enter the abdominal cavity, coils of the jejunum and ileum slides inward over the right aspect of descending mesocolon and so displace the descending colon to the left side. So here you can see, and this is the descending colon, and because of the moving and elongation and rotation of intestinal loops, descending colon finally comes to lie its position, that is on left side of the abdominal cavity. The transverse colon passes superior to the origin of the mesentery. So you can see these are the loops of the greater omentum, and this is the root of the mesentery, and you can see also this is the root of the mesentery, and this ascending colon, transverse colon, basically lies superior to the origin of the mesentery. Cecum is last to re-enter, and it first lies at first lies on coils of ileum on the right side. In this diagram you can see initially the cecum is present in the subhepatic region on the right side, but because of later all of the other portions adapting to its final position, cecum come to lie in the right iliac fossa. Also during this process of descent, a blind ending pouch is formed from the cecum. This blind ending pouch is called the appendix. So also remember, because appendix is formed during descent process of the cecum, so its position varies accordingly. What happens to the mesenteries of the intestinal loops? So you can see a different position. This is the transverse up first part of the colon, then transverse and descending colon, and these are different loops of the intestine, and finally these loops are coming to their position. Here you can see these are the layers of the greater omentum which are present over here. And so in this diagram you can see these are the loops of the greater omentum which are present. This is the transverse mesocolon of the ascending colon. This is the transverse mesocolon of the transverse colon, and this is the descending colon with the its mesocolon, and this is the sigmoid mesocolon with the sigmoid colon and the rectum, and these are the loops of the small intestine with the mesentery proper. So what happens during the process of descent and final positions of the colon, that the posterior wall of the colon comes, and also the posterior wall of descending colon, both of these come to lie against the posterior abdominal wall, and their posterior layer disappear, posterior mesocolon disappear. So the ascending as well as descending colon both become the retroperitoneal in position. As far as the transverse mesocolon is related, the transverse mesocolon comes to lie against the root of the greater omentum, and these layers fuses, but transverse mesocolon maintain itself, and the colon remains intraperitoneal in this part, that is the transverse mesocolon. Initially, when the ascending colon is intraperitoneal, there is a wide connection of the mesentery of the small intestine to the mesentery of the ascending colon. But because of the its position, when it becomes retroperitoneal, the mesentery of the small intestine acquires its final position. So this is the line of the reflection of the mesentery. It starts from the part where the duodenum become intraperitoneal to the point where the ileocecal junction is present. So this is the root of the mesentery. Here you can see descending colon. Here the transverse colon is cut to show you the transverse mesocolon as well as the layers of the greater omentum. Here you can see ascending colon. This is the pelvic mesocolon which remains, and sigmoid colon is intraperitoneal till the end. Only the descending and the ascending colons become retroperitoneal in position. So these are the positional changes which are related to the mesenteries. Now we move on to the clinical correlates of the intestinal loops, their herniation process, then the retraction of the herniation. So what are the different clinical correlates? First is the omphalocele. So in omphalocele, during the process of the physiological herniation, when the intestinal loops are retracted at 10th week of the gestation, some intestinal loops fail to come back to the abdominal cavity, and they remain over here. They protrude through the umbilical ring, and they form the herniation that is called the omphalocele. So this omphalocele is covered by both the peritoneum as well as the coelomic epithelium. And the amnion is covering it, and this is through the umbilical ring. But important point to remember is that this omphalocele is associated with other anomalies of the bodies, that is cardiac defects and other defects, and many of the cases are associated with chromosomal defects. So the fatality rate is higher in case of the omphalocele. Another condition is called gastrocisis. Usually the students confuse both the condition, the gastrocisis and the omphalocele. Gastrocisis is because of the defect in the anterior abdominal wall to close completely, while omphalocele is the defect in which, after the process of the physiological herniation, the intestinal loop usually do not re-enter into abdominal cavity. So gastrocisis is present just lateral to the umbilical ring, usually on the right side of the umbilicus, while omphalocele is through umbilical ring. Third important differentiating point is that there is no covering membrane and there is no amniotic covering. Both of these conditions, the gastrocisis and omphalocele, both are diagnosed in a prenatal life in a second or third trimester with ultrasound examination, and although this condition may be severe, but usually fatality rate with the gastrocisis is less because it is not associated with any chromosomal abnormality, and if major compromise to any part of the intestinal loop do not occur, then this condition can be corrected surgically with better outcome. Other defects which can be related to the gut herniation and rotation are the abnormal rotation. So first, either there may be absent or incomplete rotation, and in this condition the duodenal, jejunal and ileal loop are present on right side of the abdominal cavity, and the transverse ascending and descending colon are present on left side of the cavity. Another condition in which there is the reversed primary rotation, only rotate 90-degree clockwise, and in such a condition usually transverse colon is present posterior to the duodenum. So there are different degrees, different stages in errors of midgut rotation and development. First, non-rotation, leaving major part of colon on left side and small intestine to the right side, as I have shown in previous slide. Second, incomplete rotation, in which the cecum is situated in subhepatic region. It do not descend to the iliac fossa, so it remains in subhepatic position. Third is the reversed rotation. The final 180 rotation occurs in clockwise manner, so that the colon is lying posterior to duodenum and the superior mesenteric artery. And fourth may be the hyperrotation. The rotation continues to 360 or 450 degree, so that cecum rests in the region of the splenic flexures. Other abnormalities are related to the vitiline duct. So vitiline duct is actually the connection of the small intestine to extraembryonic coelom or the yolk sac, and it usually disappears completely normally. In cases it persists, it can lead to different anomalies. So this is the first, which is called patent duct or the patent vitiline duct. There is a wide connection of the intestinal loop at the umbilical ring, and usually fetal material can be seen at the umbilicus. In this condition, a part of the vitiline duct is present at umbilical ring. This may form the umbilical polyp. There is no connection of the vitiline duct to the intestine. In this condition, Meckel's diverticulum is present, and this Meckel's diverticulum, usually 60 centimeter from the ileocecal junction, is present. In third condition, although the connection is present, but over here there is a fibrous cord, and also at the junction of small intestine to the vitiline duct is the fibrous cord, but in the center there is the cyst which is present, called the duct cyst. And in another condition, whole of the connection is the fibrous cord. So this can, although there is no connection of the lumen to the exterior, but this fibrous cord can provide a loop, and because of this loop, sometimes the intestines can rotate around it, can produce obstruction, can cause volvulus formation, etc. So these are the different conditions which can lead to vitiline duct anomalies. Another anomalies are because of the compromised blood supply to the bowel in utero, that can result in the intestinal atresia. So in this diagram you can say this is the area of the intestine where the blood supply is compromised. So in first you can see mucosal atresia with intact bowel wall and mesentery. In this diagram you can appreciate that there is atresia of the mucosa, but the connection is intact. In this condition, you can see blind intestinal ends are separated by the fibrous cords. So there is a fibrous cord end is blind over here, and this fibrous cord is attaching it to this distal part of the bowel. The blind intestinal end is separated by V-shaped mesenteric defect. So here in this diagram you can see there is no fibrous cord, but there is a V-shaped defect of the mesentery. So these are the different defects. Another is the apple peel atresia. In apple peel atresia, the blood supply is compromised to the jejunum, and connection between the jejunum and ileum is lost. Proximal jejunal loop becomes the proximal jejunal pouch, and distal part of the ileum coils around the branch of the superior mesenteric artery. This condition is called the apple peel atresia. So here I complete my today's class, and the references for the today's class are the Langman's Medical Embryology, The Developing Human by Keith Elmore, and the Gray's Anatomy by Susan Strandring, the 40th edition. Thank you all dear students for your attention to today's class, and we will meet in the next class where we will do the development of the hindgut. Till then, Allah Hafiz.